Welcome to the 361st of the COVID calls. This is a daily discussion of the COVID-19 pandemic with a diverse collection of disaster experts. My name is Scott Gabriel Knowles. I'm a historian of disasters at the Korea Advanced Institute of Science and Technology. I'm coming to you live from Daejeon, South Korea. Today, I welcome pioneering HIV/AIDS and global health researcher and activist Greg Gonsalves. Just a reminder, you can usually catch COVID calls live on weekdays at 6 p.m. Eastern Time. Just go to the COVID Calls YouTube channel to watch. You can hear COVID calls anytime, recorded as podcasts on Spotify, iTunes, Podbean, or anywhere you get podcasts. You can also keep up with COVID calls via Twitter using the handle @US of Disaster or @COVID Calls. Please do help spread the word and send suggestions for future guests and future topics. And as always, please feel free to suggest yourself as a future guest. As of today, October 19th, 2021, there are 4,904,742 deaths from COVID-19 globally. That's according to the Johns Hopkins University Coronavirus Resource Center. I've been reading an obituary or a story of advocacy for those impacted by the pandemic, and I'd like to continue that now. The headline is UN/AIDS is deeply saddened by the death of Manuel da Quinta. And this appeared on the UNAIDS.org website, June 14th, 2021. The UN/AIDS family is deeply saddened by the death from COVID-19 of our dear colleague and friend Manuel da Quinta. We offer our deepest condolences to his husband Ricardo and to his family and friends in general. Since 2017, Manuel worked as a UNAIDS community support and human rights advisor for the multi-country UNAIDS office for Argentina, Chile, Paraguay, and Uruguay. But many of us knew him in the many roles he held and the tremendous work he did around the world as part of the UNAIDS family for more than 24 years, advocating for the rights and leadership of people living with HIV and the populations most vulnerable to HIV, including the lesbian, gay, bisexual, transgender, and intersex community, migrants and refugees, sex workers, indigenous peoples, and young people. Manuel represented the essence of UNAIDS' mission and vision, and the reason why all of us get up every day to fulfill our duties and purpose. As a strong advocate for human rights and social equality, he always stood up against all forms of injustice, including internally at UNAIDS, where for many years he was the chair of the UNAIDS Staff Association. Manuel was an HIV activist since 1990 and accumulated a vast experience of community work with organizations working on behalf of people living with HIV in several countries in Africa, Asia, and Latin America. He joined UNAIDS in 1997, starting in the communications department, managing multimedia projects on HIV. Later in 2005, he co-founded UN Plus, an initiative that brings together United Nations system staff living with HIV. Since then, he's worked in UNAIDS teams in Geneva, Bangkok, Dakar, and Buenos Aires. Manuel was a person with great positive energy, an enormous willingness to make even the impossible possible, bringing a deep passion to everything he undertook. He was also a loyal friend to many of us. Manuel left us at the early age of 59 years and will be deeply missed. We wish to express our deep sorrow at his passing and to reiterate our solidarity and warmth to the great community that has worked with Manuel in the HIV response over so many years, and to all those who've known him around the world and who mourn his departure. Obituary of Manuel da Quinta, the UNAIDS.org website from June of this year. Okay, I'd like to turn to my conversation for today, and this is one that we've been very much anticipating. Let me introduce Greg Gonsalves. Greg Gonsalves is an expert in policy modeling on infectious disease and substance use, as well as the intersection of public policy and health equity. His research focuses on the use of quantitative models for improving the response to epidemic diseases. For more than 30 years, he worked on HIV, AIDS, and other global health issues with several organizations, including the AIDS Coalition to Unleash Power, the Treatment Action Group, Gay Men's Health Crisis, and the AIDS and Rights Alliance for Southern Africa. He was also a fellow at the Open Society Foundation and in the Department of Global Health and Social Medicine at Harvard Medical School from 2011 to 2012. He is a 2011 graduate of Yale College and received his PhD from Yale Graduate School of Arts and Sciences and the School of Public Health in 2017, and he is a 2018 MacArthur Fellow Award winner. Greg Gonsalves, welcome to COVID Calls.
Thanks, Scott.
So let me start the way I generally do, just find out where you're calling from and what the pandemic situation looks like there today.
Well, I was prepared for this one. I'm calling from Connecticut, in the United States in the Northeast. The New England area is one of the most highly vaccinated areas in the country. We have about 70% of people fully vaccinated, and we have very, very few deaths, hospitalizations, and cases in the state right now. We have about 609 cases daily average over the past week, about half of that hospitalized, and then a very, very small proportion, about 7 people died of COVID-19 over the past week or so.
I mean, what about at Yale? Have things sort of resumed something that looked like pre-COVID? What are the protocols?
So we've had very few infections at Yale. What's important is that we've had vaccine mandates at Yale, and so all the student, staff, and faculty have been required to have been vaccinated, and the compliance has been extraordinary, in the upper 90s. I think for all of these constituent parts of the university, staff, students, and faculty. And so we've had very few infections. That being said, masking is mandatory indoors, but we also have an indoor mask mandate in New Haven, which Yale is part of. And so while we're having classes face-to-face, which is great to see students and faculty and colleagues again, mask wearing and vaccination is sort of the core of what we're doing here at Yale.
I've heard people use language, like endemic, and to say that there's parts of the United States where you could even say COVID-19 is now something people live with, or it's endemic, while other parts of the country it's still pandemic. I imagine that's a sort of mangling of epidemiological terms, but the sentiment is real. I mean, how do you describe the variability across, let's say, looking from Florida, Texas to Connecticut? Because they are different worlds in terms of risk right now.
Yeah, so look, I mean, epidemics are a stochastic phenomena. That means they have a certain amount of randomness inherent in them as something that happens in the world. So lots of stuff in the epidemic we can't predict, and it has its own idiosyncrasies that we can't put into our models. That being said, the vast majority of infections that are happening around the country, the vast majority have hospitalizations and deaths are among the unvaccinated. And if you go on the New York Times website or whatever your favorite aggregator of US data is, you'll see that there's state by state stark differences in the number of people who are vaccinated. And so, again, like 70% of people in Connecticut are vaccinated. That's not saying we've reached our goal, nor that there are sort of disparities within that 70% fully covered that we have to address. But there are states in the American South that have far fewer people vaccinated as a proportion of their populations, and while there may be some randomness, seasonality, whatever you want to think your favorite sort of covariate in your model might be, the fact that vaccination is probably the predominant driver of what's happening in the U.S. now with the pandemic.
So, like others, I follow you on social media, and I keep up with your columns. So in many ways, I've kind of ridden along this pandemic with the issues that you're writing about and that you're talking about. And having said that, I still want to ask this question about a memory that you might have, something that really sticks with you that defines this pandemic, something, your own personal experience with the pandemic that you might be hanging on to as a kind of signature memory of this time.
Well, as we sort of get closer to 2 years of living with this virus, there's sort of lots of different touch points. I remember being on a phone call with a friend of mine from New York City early on in the pandemic when, the mayor of New York and the governor of New York were sparring it out for who was in charge of this newly emerging health crisis. And there was even fights between the health department and Health and Human Services in New York City about who was in charge of the pandemic, which led to delays in New York City's response to the pandemic, with all this bureaucratic infighting. And I remember that very clearly, the sort of desperation of people, even in sort of states that subsequently have done fairly well with vaccination and controlling the epidemic 18 months, 2 years later. There was an early memory that's pretty clear with me. The earliest one is when we got together in a conference room here at Yale to work with our Chinese colleagues and postdocs and faculty to think about what was happening in Wuhan and the People's Republic, because early on we had no conception that this was really going to be a worldwide pandemic. 2 weeks later, of course, everything changed, but really early on, we didn't have any real conception of what was about to befall us.
Yeah, that sparring among different agencies, I mean, was that a signal to you? I mean, you're a person who's followed public health and public health agencies for a long time. I mean, that for people on the outside who might not know how to translate that might have just seemed like normal bureaucracy, but you're pointing to something I think is really important.
Well, I mean, you're a disaster historian, and there's a person, Juliet Kaim, who I was part of a New York Times discussion about vaccine allocation months ago now, and we were chatting offline during preparation. He talked to me about a book called Katrina: A History, 1915 to 2015, with the idea that Katrina was a singular hurricane in terms of meteorological history, but in real sort of the history of human events, it was paved, the way it was paved for over a century in sort of policies in New Orleans, Louisiana, and the greater Gulf region. The bickering between public health officials, the sort of lack of preparedness, the sort of total hot mess that we saw with the federal response, is characteristic of our sort of fractured, weak public health system in the U.S. and our sort of the state of our politics, over the past decade or more. And so, epidemiology, outside of the politics, is sort of an ivory tower conception. The mathematical models we design and we execute can tell you a lot about how the virus might do without human intervention, besides for vaccines and treatments, et cetera. And nobody could have predicted the sort of nobody could have really believed the kind of response we had from our federal, state, and local agencies back starting at the beginning of 2020.
I'm glad you name-checked the Katrina book too. That's a colleague of mine, Andy Horowitz, wrote that book, and it won the highest award you can win in the American historical profession last year. So it is. I mean, I think it's a good one to point to, that there's a lot of preconditions that go. That's not something that just unfolds over a day, over a weekend, as it appeared, I think, so many people in March. I want to come to a more recent sort of episode in your work, and this was a story that appeared in the New York Times in September. I'm just going to read the lead of the story because I think it really sets a tone. They wrote, a small band of longtime AIDS activists, fed up with what they regard as President Biden's failure to scale up coronavirus vaccine manufacturing for global use, deposited a fake mountain of bones outside the home of Ron Klain, his chief of staff, on Wednesday to represent the lives that they say have been lost to the president's inaction. And there's is a photo there, and there's a U-Haul trailer, and there's a picture of a pile of bones, and there's Greg GONSALVES. And it's quite a story, and it's I think it bridges maybe some important moments in your career, because I wanted to really start with this, because I think it it brings so many different aspects of the things you've been working on together. So I mean, guess basic question: why did you do this at Ron Klain's house? Why drop off the bones?
Well, first of all, I may be sitting in a university now and pretend to be an academic in my daily life, but the point is my history is really in AIDS activism and health activism. I worked on AIDS, I worked on a whole other set of diseases, from hepatitis C to TB, Ebola, over the course of my career. And sometimes science isn't enough. Sometimes sort of the standard ways of getting attention, op-eds, meeting with your member of Congress, strongly worded emails and phone calls are not enough to wake people up to what's happening. And just like in the early days of the AIDS epidemic, there was sort of an inertia or even a benign or malign neglect in terms of confronting the pandemic. And in the context of COVID vaccine scale up, well, we're talking about 70% vaccination in Connecticut and high vaccination coverage in many other places around the US and in some other countries around the world, like Portugal, for instance. Most people in the global south, particularly in Africa, have very little access to vaccines. And it's not an epidemiological crisis, an industrial crisis. It's a political crisis. There is some strange reticence or resistance in the White House to scaling up mRNA and other vaccines outside of the context of what the original manufacturers, the originator companies, want to do. Groups like Public Citizen in DC, Prep for All in New York City, Thomas Frieden, who's the former CDC commissioner in the US, and his group Resolve to Save Lives, have all said we can scale up mRNA vaccines much more quickly by sharing the technology with contractors in the US or with pharmaceutical companies around the world. And there's pretty widespread consensus among clinicians, scientists, advocates, global health leaders that this needs to be done. But there's singular resistance in the White House that is either from David Kessler, Jeff Zients, Ron Klain, or the president himself. And so we thought going in front of the president's house would probably be not very interesting because people protest from the White House a lot. But the closest person to the president is Ron Klain. And there's good reason to believe that he's giving the president advice that it doesn't matter. It's not a political deficit for you if you ignore the global pandemic. We have to keep sort of the pharmaceutical industry on our side, whatever. Ron Klain is obstacle number one to global vaccine scale up. And so we went to his house. We went during the middle of the day. Nobody's likely to be home. We understood that, going to somebody's house is sort of an escalation which could offend some people. We went in the middle of the day. We didn't scream or use bullhorns. We didn't make loud noises. We brought a pile of bones. We had a press conference for about 20 minutes while the Secret Service watched us go about our business. Incredibly peaceful, respectful, but not respectful of Ron Klain's role in perpetuating vaccine apartheid.
It really, thank you for explaining that. And I mean, it really taps into kind of a challenge here with COVID, which is sort of discovering who the advocates are. And, there's the long COVID community, I guess, but it's pretty disparate. And they haven't yet, there's not sort of one national organization that I'm aware of that's advocating. And so I wonder, I guess my question is, how do you think an action like that can build? I mean, it does seem like there needs to be a sort of broader social movement around vaccine access, but then many other aspects of healthcare access that COVID provides.
Well, it's interesting. The conversation I told you about at the beginning of this broadcast with my friend in New York runs an AIDS organization. We were talking about a public health leader in New York City we were talking about two public health leaders who were sparring with each other whose history was in AIDS. So while we don't have sort of a contingency like we had for ACT UP in which people living with AIDS and their advocates sort of were leading the charge for efforts on the disease, many of the people who cut their teeth in ACT UP and have dealt with the AIDS epidemic internationally or domestically have been on the front lines of the COVID pandemic. One is because they work in infectious diseases. And like everybody in my department here at Yale, everybody went from whatever disease they're working on to COVID. Many of the activists and advocates, which included, direct action people like me and the others who were at Ron Klain's house a few weeks ago, but sort of stayed researchers and clinicians, have really taken up the mantle to sort of push ahead some of these issues on sort of COVID vaccine access, but a whole range of other issues. It's a lot of infectious disease epidemiologists, clinicians, people who come from the AIDS movement on the sort of advocacy side who've been at the forefront of this, and it makes sense. COVID is a worldwide phenomenon. We're all affected by it. Um, those of us who've worked in AIDS and have seen one pandemic go by, two pandemics, if we want to count TB, three if we want to count HCV, really have a wealth of experience and sort of muscle memory in terms of dealing with sort of recalcitrant governments and drug companies, and sort of sprung into action and know what to do. And so, that's what a lot of the work is being done. I'm on a daily WhatsApp chat with people from all around the world. It's access to medicines people, many people who we've known each other for 20, 30 years now because of the fight for antiretroviral drugs around the world. It's not a mass movement, but it's definitely a global movement of people who've been fighting for access to medicines for 20 plus years.
Just a reminder, you're listening to COVID Calls, and I'm talking today with Greg Gonsalves. And I think that, that base is a really important one to explore. You said dealt with one pandemic went by, and maybe we can count two, and maybe we can count three. Somebody with your experience, I mean, that's really crucial right now to understand, as you said, how do we get beyond the science, or that the science isn't enough. I guess with that in mind, I hope it's okay. We can go back and maybe sort of paint in some of your earlier history as an activist, because I think drawing that connection across time is really powerful and important. So you were, I mean, the protest with the bones at Ron Klain's house, I mean, it seems to me, to borrow a page from AIDS Coalition to Unleash Power, ACT UP, which I think is where you got your start in public health work, if
Yeah,
I'm right.
yeah.
So how did you discover ACT UP, and what was your role there?
So ACT UP was started in 1987. Larry Kramer and a group of other people, so it's not just Larry, met at the Gay and Lesbian Center in New York City to sort of say, look, this is not enough. The sort of nascent service industry that was caring for people living with AIDS was not enough, that we needed a political movement to sort of spur government action on research and development, treatments, civil rights, etc. And ACT UP, started in 1987 in New York, but it rapidly exploded all across the world. There's a French movie called Beats Per Minute, which is about ACT UP Paris, but there are chapters all over the world. I first joined in 1989, 1990 in Boston because I had met somebody who was HIV positive and was the first person I knew with HIV, but there's no internet, no place to go for information. So I looked for information and I found a flyer for ACT UP. I got there, so lots of people looking for similar answers, and frustrated that there were not a lot of answers in terms of what was available for treatment. And there are companies and there are politicians in our state of Massachusetts that were blocking access to drugs through expanded access, or important bills and appropriations at the state level for AIDS, like Michael Dukakis, who's the governor then. And so got involved in ACT UP, moved to New York and joined the mothership, which was ACT UP New York, and joined the Treatment and Data Committee, which is very focused on drug development and research, and threw myself into that. Although I was trained sort of initially in sort of literature and comparative literature, I had a little bit of science background, and threw myself into that work, and worked on a whole host of issues. But in around 92, as ACT UP started to spin apart, like many social movements do, there's a book, Poor People's Movements, by Francis Fox Piven, that talks about how social movements have these sort of life cycles. ACT UP was reaching sort of a crisis point in its life cycle, and treatment action groups spun off. And my friend Peter Staley, one of the first pieces of work that was done as a treatment action group was putting a condom over Jesse Helms's house. And so the bones in front of Ron Klain's house were Peter's idea. And we worked with the gay mafia of Broadway scene shops in New York to make that prop, just as he had made a giant condom to go over Jesse Helms's house back in the early 90s. And so, well, the two of us were the sort of the old guard. There were sort of newer AIDS activists there, but I joined ACT UP. We formed Treatment Action Group, and then the rest of my life sort of proceeded from there.
I found an article in the New York Times. I went back and from 1994, it shows you sitting at a meeting, sitting next to President Bill Clinton. I think it was the first meeting of his HIV/AIDS action group I guess I don't know if it was a cabinet level. I'm not quite sure of the context, but there you were representing the treatment action group. And again, I mean, first of all, I think it really speaks to the time in which you go from sort of one presidency, and I guess Reagan Bush presidency, to another in which HIV/AIDS is no longer just an issue that the United States government can sweep aside or say this is part of a marginal group, so we don't pay attention to it. So I mean, I think it speaks to the success of ACT UP and Treatment Action Group. But I wonder if you can cast your mind back to that time. What was possible then? I mean, in terms of politics, but also in terms of the science.
So a couple of things. One is that was the White House Conference on AIDS, the one and only. Um, you know, I remember being in a hotel room in D.C. or suburban Virginia or Maryland during an AIDS clinical trials group meeting, a scientific meeting with a bunch of AIDS activists on election night when Bill Clinton got elected, and their tears flowed. We had made it through the Reagan and Bush administrations, who had been just spectacularly horrible on HIV, and all of a sudden we had a new president who was going to change things. Fast forward, and we were gravely disappointed. The president really didn't make AIDS a priority. He ended up doing "Don't Ask, Don't Tell." I mean, a whole maintained the ban on needle exchange. He was a complete disappointment to us. And so at that White House Conference on AIDS, which is early on, we were sort of laying out our agenda, and I was talking on research and said we should double the NIH budget. It'll never happen. It did happen, and it wasn't my fault. It wasn't my idea, but I think biomedical research funding was sort of a bipartisan item which could make its way through the sort of 90s sort of triangulated politics. But all the other important things, we really didn't get much out of the Clinton administration, and we're deeply disappointed. Until 1996, we didn't have actual treatments that could save our lives. We were working with drugs like AZT, DDI, DDC, D4T, which we were like, does it do anything at all? Does it keep you alive? And having sort of tortured discussions with FDA and others about how to do trials to a certain small and sort of medium-sized benefits from these sort of not very potent drugs. In 1996, things changed. We're still in the middle of the Clinton administration. And towards the end of his term, it's pretty clear that these drugs are game savers, but game changers. But this will remind you of what's happening now, that most of the world can't get access to them. And the Clinton administration was blocking access to these AIDS drugs by threatening trade sanctions or putting people on a watch list, countries like South Africa and others, for talking about generic production and breaking patents on these drugs. And so everything old is new again. The fights we had with the Clinton administration as it exited at the end of the last century are starting all over again about who gets access to life-saving medical interventions, whether it's AIDS drugs then or vaccines now for COVID. A lot of the same fights are just happening in the same almost exact way, except for the agents involved.
How did you understand that hesitancy at that time to not be more aggressive with funding for life-saving treatments, but also for vaccine availability? And I mean, is this the power of big pharmaceutical that is bipartisan in the United States in the 1990s, or is there something else here? I mean, there's still that the LGBTQ community was somehow still politically marginal, and so even a Democrat could get away with sort of having a meeting and then saying we've done our work here and moved on. I'm just trying to understand how a president can say no to something which is so obviously that's such a morally bankrupt position. I mean, so obviously morally bankrupt, and yet both parties do it.
Because we don't matter, right? I mean, I just wrote a piece for The Nation this past week, talking, and to be fair to the Clinton administration and all other presidents, we've done this for like centuries, right? I went through sort of history of science and medicine and the sort of way we've sort of addressed cholera, yellow fever, smallpox in the United States. It's about who has power and who doesn't have power. And the gay community was an important constituency of the Democratic Party, but we weren't that powerful. And so when it came to push comes to shove, if you're trying to show America that you were tough on drugs, you'd maintain the ban on needle exchange. If you wanted to show that you were not hostage to special interests, you'd cave in on don't ask, don't tell. And so, like, we were not high on the agenda. It's Larry Kramer used to call us, said we were treated as disposable people. And we don't matter in DC. We were they were willing to write us off if there were higher interests involved, and a lot of the times that's about the pharmaceutical industry. In the context of AIDS drugs and COVID vaccines, the pharmaceutical lobby is incredibly powerful in the U.S. It's the largest lobby in DC. It's bipartisanly integrated into sort of both parties in the United States. Kathleen Rice, who represents my district in East Meadow in New York on Long Island, where I grew up, Democrat, but has been key leader against sort of drug pricing reform in the current Biden bill that's passing through Congress. And you're like, really? And then you just start scratching the surface and realize how much money she gets from the drug companies. Same with Kristen Sinema in Arizona. There's a large sort of blood-sucking squid phenomenon that is the pharmaceutical industry in DC, and they're incredibly powerful. And they think they own the FDA. It's pretty clear when we talk about COVID vaccines that they think they own the White House. Albert Bourla screams and yells anytime anybody talks about anything that sort of breaks the mold of his absolute monopoly control on his vaccine.
I'm thinking numbers I looked at, excuse me, that maybe there's something like 3 full-time lobbyists for every senator. I mean, there's a staff, full-time pharmaceutical lobbyists for each senator.
Yeah, I mean, it's enormous. And, even before COVID, many of us worked on FDA issues and drug approval issues. We are seeing a sort of vast deregulation of the pharmaceutical industry and drug approval, which is, if you know the history of FDA, and Francis Kelsey and the thalidomide disaster and sort of the whole history from the beginning of the 20th century about patent medicines, we are moving back in history to the beginning of the 20th century, not the 21st, in terms of what's happening. And it's largely because it's pharma that wants to sort of roll back key protections that are embedded in FDA law in the United States. And this was before COVID, right? So there's a deregulatory agenda that's sort of been on the march for a long time in DC. And it's about ceding control to the industry to do what it wants, when it wants, and in the way it wants. And the idea that the White House would exert pressure through the Defense Production Act or other sort of mechanisms is just they must just say, like, how could we possibly do that? Even if it's legal under the law, think of the consequences to us and our campaigns and our party. And if we disappoint pharma, they're just going to go to the other side and support. I mean, it's just that's the kind of logic that seems to be at work. It's not about public health or human lives. It's about sort of cold hard political cash. It's Citizens United redux.
Yeah, I have to say, Greg, I mean, you're situated in public health, but you're a powerful advocate for historical thinking. I have to say, I mean, as a historian too, I'm happy when you talk about the history of science, and I think it's important in many different ways. Well, one, I mean, you said, I saw in 2018, after you won the MacArthur Award, you told NPR that AIDS for you was a wake-up call. It wasn't just a virus, and I'm quoting you here. The epidemic was man-made. Infectious disease will always be with us, but epidemics are a human creation. And that's a powerful statement, because it's not to downplay the science and the role of the science, but that it's sort of a chastisement, in a sense, of a modern society that thinks if we just get the science right, and if we get the technological fix to our problem, then we'll solve it. But your discussion about pharmaceutical deregulation taking us back to the early 20th century, I mean, that's a correction of that. And I think that's an important point, but it kind of puts us back in a tight spot in terms of how do we know what to research, what strings to pull. There's only so many hours of the day, to do our scientific research or to do our social science research and to be activists. It's exhausting to do all of it. So I guess my question, I just want to get you to expand on that idea a little bit because I agree with your analysis 100%, but it leaves us in a place wondering how to act, I think.
So I think I said, infectious disease will always be with us. Epidemics are man-made human creations. Back during the Ebola pandemic in West Africa, and I rehearsed, I revived it for 2018
Mm.
during the MacArthur stuff. But it's pretty clear that so there's two authors who have been very influential to the way I think about things. There's a guy named Alex DeWall, who wrote a book called Famine Crimes that talked about how sort of the humanitarian international sort of has perpetuated itself and perpetuated famines, and that famines are political constructs. It's not about food scarcity. It's about political decisions that create famines, and relying on sort of ideas from Amartya Sen that like famines don't happen in democracies, etc. And so, the idea is that the AIDS epidemic, the Ebola epidemic, the COVID-19 pandemic have epidemiological roots, but their explosion into pandemics really depend on human agency. And then there's another book called Why Nations Fail that Daron Acemoglu and James Robinson wrote several years ago about sort of sweep of history of sort of ups and downs of human society. And there's this one paragraph in it, and I think it's in the introduction, and I'll mangle it, but they said, poverty doesn't happen by accident or mistake. It happens by political choices made by political leaders, right? And said, why nations fail is not because, guns, germs, and steel, or something in the character of various nations and continents and countries. It's that predatory elites create conditions for poverty, and strip countries bare in a way that is consensual by political elites. And so as I read that, I'm like, gee, that seems pretty apt in terms of ill health. The reason that people die from COVID and don't die from COVID, the people who are getting vaccines and don't get vaccines, is not about whether we can make them, whether they're effective, whether the science is right or wrong. It's because somebody in the White House, somebody in a boardroom decided that it was not important for people in Senegal or Cote d'Ivoire or Kenya or Mauritania to get access to these vaccines, that they didn't matter, that they were disposable as we were during the AIDS epidemic.
So in 2006, you moved to South Africa and spent a few years there. And it seems like that was a turning point for you, maybe out of your role in the Treatment Action Group and more sort of activist-centered organizations. Maybe give us some context for that, because there was from then you went into public health after that, into academic public health.
Well, so Zaki Akwa, who ran the Treatment Action Campaign, or was one of the leaders of the Treatment Action Campaign, a South African group, back in 2000, came to New York because he was a gay man he knew, and an artist. Made films with his lover, then roommate Jack Lewis. Knew sort of the LGBT community in New York, and came to me and my colleague Mark Harrington at Treatment Action Group and said, we realized how you trained yourself to understand the science as non-scientists. We just started this group called the Treatment Action Campaign. Would you come to South Africa and help us set up some trainings to teach our members? And we were like, sure. And we had no clue. I mean, people like Health Gap and other organizations who had done earlier treatment access work in the late 90s were all over this, but we were very focused on the US situation. Went to South Africa, realized, Jesus, this is not like Treatment Action Group or ACT UP. This is a huge mass movement. They can bring 30,000 people in front of Parliament. We could never bring anything like that. And so went and did trainings on AIDS science and medicine and opportunistic infections and all of it, immunology, everything, for the members of TAC, largely who were poor people from townships with rudimentary education, but who easily, with a little bit of over the course of 3 days, could master the basics of the immune system, how the virus works, etc., and turned it into this giant sort of world, nationwide campaign of treatment education in clinics and in townships all across the country. That was a heady time. The AIDS conference in Durban in 2000, Nelson Mandela, Bill Clinton, others challenging the world about medical apartheid with antiretroviral drugs. And it shifted the sort of thinking of many AIDS researchers across the world and AIDS activists across the world that we had a sort of international global fight.
Mm.
And in those early years of the 2000s, um, I and others formed an international treatment preparedness coalition, which was a global coalition of sort of act up like organizations, sort of feisty AIDS organizations all across the world, from Moscow to New Delhi to to La Paz, etc. And I was part of a global movement which was about HIV, but started to become about TB and HCV, which were killing people across the world. And the only reason I went back to school is because now by this time it'd been almost 20 years well, at least between 15 and 20 years in the trenches doing this work, and I wanted a little bit of a break. I didn't realize what was going to happen afterwards. It was not really planned really well. So I just ended up getting an undergraduate degree, in my 40s rather than in my 20s when I should have. And I didn't plan on being a public health PhD student nor a public health professor. It all sort of just happened.
Well, I want to come back to that in a second, but just to come to South Africa, maybe you talked about a mass movement that can bring 30,000 people to a protest. Is that because of the scale of, the virus and the impact there and the population, or was it because, you just used the word apartheid. Is it because South Africa was itself going through this radical political transformation, had just been through it and sort of casting off apartheid? It's not over. I don't want to say that, but that was a political convulsion at that time, and AIDS and anti-apartheid work are joined at that time. That's really public health and
Yeah.
politics in one, right?
Yeah. So a couple of things. One is it's the biggest AIDS epidemic in the world. So like people's own sort of motivation to sort of act up was huge. But many of the leaders of the Treatment Action Campaign and other groups were anti-apartheid leaders. Zaki Ahmad got arrested and sent to jail for trying to burning down his school. Many of them were part of the Marxist workers' tendencies, some splinter group in South Africa during the 80s and 90s, and many of them were lawyers that represented people during the apartheid years, etc. So like there was a movement history that this built on, but also the LGBT movement in South Africa, which ended up with a constitution which enshrined the right to gay marriage way before to LGBT rights before we had done so in the United States. So there was a much sort of richer history of mobilization that they built on. That allowed them to sort of do this mass movement. They had the chops in organizing from the anti-apartheid movement. That being said, I don't understand why we couldn't do it in the U.S., but I think it's because it was this much more concentrated epidemic among gay men and other marginalized groups, unlike the sort of generalized epidemic they have in South Africa.
That's an important insight, because that intersection of the struggle for racial equality, LGBT equality, and then public health access in South Africa is one you would think it would happen in the United States. And I guess that sort of brings us back into COVID and the context of last year with George Floyd's murder and the obvious inequalities which break along many fracture points in the United States, but racial is certainly one of them. Those intersections are so obvious to me, to anybody who takes a minute to look at them. And this South Africa case is a powerful one to work with. And yet I still don't feel like we've seen that intersection in terms of a mass movement of people in America calling for racial equality, LGBTQ rights, and health simultaneously. Or it's there, but it's not at the scale that I suppose can make vaccines broadly available, or that can increase research budgets. It's not accomplishing what it needs to. And I don't mean to editorialize here, but I just wonder your sense of that, why it's not yet happened in the US.
Well, look, my nation piece last week basically sort of lays the failures in American public health at the feet of white supremacy and sort of our history of racial segregation and slavery. And so if we don't confront race in the United States, we're not going to confront our public health crisis, which has been about depriving the undeserving of resources. That being said, all my life almost, the right has been organizing against sort of any kind of solidarity, right? And creating, what oh God, Timothy Snyder has called pseudo-populism, a sort of populism that actually gives people some sort of status um, through their whiteness, but takes away everything else right from underneath them, right in their faces um, as they sort of stoke sort of division. And it's been a very powerful tool in the United States. It still is. All the debates about, vaccination and all the discussions about Black Lives Matter, it's all been about politics of division and
Mm.
separating people and getting people to work against their own interests. There's an obvious connection to racial equity, to health justice, to environmental justice, to LGBTQ equality. It's all tied together. But these connections have not been made. We work on lots of single issues in the US, and we don't have sort of a united democratic front to sort of say, let's put all this under one umbrella. Let's get rid of these monsters, and then we can hash out all the details about these individual policies later on. But the Democratic Party, going back to Clinton, we're still Dick Morris's children. It's all a bit about sort of appeasement and sort of triangulation and meeting the Republicans halfway. I mean, essentially, Joe Manchin is the president of the United States right now. The vast majority of Americans in the Democratic Party support the president's bill, which is really the largest piece of social legislation in my lifetime. But one man is holding it hostage, and because he can do it from parliamentary means, but he also has a lot of support in terms of the sort of chattering classes of political pundits who really think this is the way the world should work.
A constant tacking to a center that doesn't achieve these sort of large scale breakthrough moments in policy.
A center that is actually to the far right of where Americans are, at least on this bill.
I want to first of all remind everyone that you're listening to COVID Calls. I'm talking to Greg GONSALVES today, and Greg, let's go back. I don't want to spend too much time on Donald Trump, but I do want to kind of go back earlier in the pandemic to that period, and you were talking about it earlier in the conversation. And what started to play out in the spring in terms of the Trump administration's response, his own response, the way he talked, and then even what was happening in HHS and CDC. Was there anything in there that surprised you? Was there anything in there you felt you could intervene in? Like, we all watched it playing out in real time, and those of us who study disasters were like, I just couldn't believe the obvious tools and steps that were at their disposal that they just dismissed.
I mean, last year was a catastrophe. I mean, it just, early on, Yasmin, I don't want to butcher her last name, but Yasmin from the Washington Post wrote a book about the sort of Trump experience of the pandemic, and she found an email that I had sent to the White House last March, to Fauci, to I'm repressing all these names: Robert Redfield, Debbie
Right.
Burke,
Yeah.
but everybody I could think of, the head of HHS, Alex Azar, and I said, "What are you doing?" We're looking for leadership and we're seeing none of it, thinking that I could appeal to them on sort of rational grounds. And Tony Fauci wrote back to me saying, I always will tell the truth. But Tony and Debbie Burks and Robert Redfield, all people from the AIDS epidemic. I mentioned to you that many people from the AIDS epidemic were leaders over the past year and a half in sort of challenging the Trump administration and the fallbacks of the Biden administration. But Tony and Deb and Robert Redfield just capitulated. And I don't care what they tell me in retrospect or in real time, is that they went along to get along. They thought being on the inside was more important than sort of intervening at that point. Yeah, a lot of people were frankly evil, incompetent, buffoons during that time, from Jared Kushner to the president himself to the rest of the sort of rogues gallery that we can name of, Scott Atlas, for instance. But what about the sort of rank and file people at CDC, NIH, and in HHS, Tony, Deb, and Robert Redfield? Three of them could have gotten together at some point last year and said, enough is enough, and sort of called the question. Maybe that's not how it works. Their lives have been public service all along. But like, we went through hell last year. We made the pandemic incalculably worse, and nobody within the administration seemed to, lifetime civil servants nor political appointees wanted to sort of challenge the president. It's really the darkest day in my lifetime in the United States.
Do you think it's left lasting harm in the public health community, in the infrastructure, CDC and HHS? I mean, it's a little too soon to say, maybe, but I asked this question because you wrote in The Nation about Scott Atlas recently, and that even for this short period of time in which somebody like Scott Atlas gets a national platform to spread herd immunity ideas, it matters. It has a long tail.
Well, look, first of all, not to go back to historians, but Elizabeth Fee, who's a historian of public health, said, we've never given a damn about public health in the United States ever, really. We spend 3% of every dollar on public health compared to the rest of healthcare. So public health in the United States has been in a shambles for decades, potentially centuries. Jim Downs, who's another historian, talks about the response to cholera and yellow fever and smallpox, cholera and smallpox in post-Civil War America, and the way in which they turned a blind eye to what was happening among freed slaves because, frankly, they didn't matter. And so we've had like a disaster of a public health system for years on end. And so never really sort of rising to sort of the level of what we needed. Before the pandemic, we had lost 60,000 public health workers after the Great Recession in 2008 who never came back, and probably 100,000, 200,000 more we needed to sort of just fill the gaps before COVID-19 hit. We've had a weak social safety net. Elizabeth Bradley, who was a colleague of mine at Yale before she went to go run Vassar, said the difference in life expectancy in the US is probably less due to healthcare spending than it is to social service spending. So we have a frayed social safety net that and a weak public health system, all based on the idea that if you start universal programs that protect public health and offer social protections, you got to give it to everybody. And it starts to say we're all deserving of a basic baseline of public health and social protections. So we had a whole lead up to the pandemic, which set us up for failure. And so when people say, "Oh, what happened to public health during the pandemic?" It's like you get what you pay for. It was already a mess, right? And there's been a meme or an idea that like public health, because of the way the pandemic played out and with things we talked about, was its own worst enemy last year. There's a lot of misinformation. There's a lot of scapegoating. There was a lot of manipulation about public health information. It was designed to confuse people, but also to make people suspicious of public health advice, of the state in general. There's a huge investment in saying that the state has no role in our societies because the market's going to provide, right? This is sort of Reaganism all the way through the past 40, 50 years. You had to make it happen. It really, Scott Atlas, Ron DeSantis have a vested interest in making government not work for you, and they did it spectacularly over the past year and a half. The state is in your way. It's an obstacle to freedom, and there's no good that can come out of public health, whether it's vaccines or masks.
Do you see the disinformation campaigns and the anti-vax now becoming mainstream in the United States as growing directly from that? I mean, you think it's just a partisan political tactic, or because it seems to merge with so many other QAnon and other kinds of groups? It's this big agglomeration of conspiracy and anti-government thinking. And of course, it's cost a lot of lives. But what do you owe that to?
Well, remember, the weird thing about anti-vax stuff is that, yes, there's sort of the new sort of right-wing vaccine conspiracy theories, but Robert F. Kennedy Jr. has been a strong anti-vaxxer for a long time. There's a joke I heard once: you want to find an outbreak of preventable childhood diseases among the unvaccinated, go put your Whole Foods on a map and draw a circle of 50 miles around it. There's a left wing crunchy hippie version that, I'm not going to pollute my body with things like vaccines, that also draws the anti-vax movement from the left. And so it's a weird, strange sort of cultural phenomenon that people like Dan Kahan here at the Yale Law School have talked about, in which we have like tribal resistance to vaccination and other sort of medical interventions that transcends ideology. It's more about group membership and group affiliation and group belonging. That's not just about the loony right; it's also about the loony left.
So, what's possible right now? Have we topped out in the number of Americans who are going to get vaccinated? Is there still a way to increase that number? I want to get into a few vaccine issues before we are out of time here.
So one is, for all my criticism of President Biden on vaccines around the world, vaccine mandates have been really, really important. Everybody's like, oh, this is a horrible thing to do. You shouldn't have done it. As people come up to the deadlines for these vaccine mandates, airlines, school districts, et cetera, they're getting vaccinated by and large, right? They've been really, really important in helping to shape social norms around vaccination. There's a whole bunch of people in the health professions and police and other places in which they're like, it's my right not to be vaccinated. Well, actually, if you went to elementary school in the United States, you were vaccinated against measles, mumps, and rubella, diphtheria, and a whole bunch of other things. So like, maybe, but you did it before, you got to do it then. What's more important to me is that, in New Haven or New York or other cities, in quote unquote blue states, there are pockets of of lower vaccination too. And it's not about ideological resistance. It's about the fact that, we talked about the sort of deficiencies in American public health. The deficiencies in American public health are also regional and geographic. There are zip codes in the US that have had worse life expectancy than others that are a 10-minute drive from each other. And those are the places where we're having trouble with vaccination. We've underinvested in public health and in an infrastructure of care in many communities around the US, and we're paying the price because there's communities that, are a short drive from me that have a lower vaccination rate, much lower than the community I live in. And that's much more sort of amenable to sort of getting people vaccinated than sort of to hardcore sort of anti-vaxxers, from the right or left. But we still haven't done enough to sort of reach those who are reachable.
And in terms of, and you've used the term vaccine apartheid, and this is a callback to the earlier part of our conversation. Can progress be made on that? I mean, are we in an interim moment where we're finally going to see some justice, and the mRNA producers are going to have to make the patents available and the IP will be relaxed? Or do you think they're locked in on this?
I don't care what they are. The point is like, we don't give up. I mean, yeah. The Ron Klain demonstration, there are 4 of us in front of the house. Okay, there's more than that, about a half dozen of us. But keep your ears and eyes open for what happens over the next few days. There's going to be escalation. There's a whole group of people working around the world, around the clock on these issues, not just about the patents and TRIPS waiver, but about tech transfer and a congressional strategy to figure out how to sort of support the WHO hubs on vaccine production. So there's a lot of people working whose energy and commitment have been flagged. The interesting thing is many of the people who've been fighting the AIDS fight, who are fighting the COVID fight now, we've been around for 30, 40 years, and we've seen George Bush, we've seen Ronald Reagan, we've seen Clinton, we've seen presidents come and go, and we're still here. And most of us, some of us are getting long in the tooth, but many of us, there's a whole new young generation of people who are committed to these sort of equity issues in health, and we're not going to give up. I mean, the president would like us to go away. Ron Klain would like us to go away. Jeff Stein would like us to go away. It's not going to happen.
I really appreciate that, and also not giving too much oxygen to the anti-vax movement, but actually talk about the mass movement on the other side for healthcare. I mean, my question, I guess, if somebody says to you, hey, Greg, I want to get involved in that. I want to be there at the trailer with the bones or whatever the equivalent of that is to try to really get people around the world to wake up to this. What steps can they take? Because I think COVID is hard in that regard. So much of the suffering has been behind doors. It's hard to know how somebody can intervene in something of scale, this magnitude, this global scale. What should they do?
I mean, look, if you're a student on a college campus, Partners in Health has PIH Engage. There's student groups. I would head towards groups that are working on healthcare access. Public Citizen in DC is not a membership organization, but there's a group called Right to Health Action that sort of sprung up to do webinars last year, just to sort of inform people about the latest science and the latest sort of political stuff that was going on. They have like tens of thousands of people now in their database, which they are turning their sights on Congress, right? So they're using these people who are part of webinars to build this huge movement to push people on COVID. But these people are also going to be important for right to health in general as we see the COVID pandemic recede in our future. So there's smaller groups that are doing this work. They're out there. I would look for healthcare access groups. There's not like a mass movement. I don't think it's Move On or Indivisible or any of these sort of groups that sort of worked during the sort of Trump era against the gross excesses of the administration. But there are groups that have been around for a long time working on health equity and health access all over the U.S. And people can plug in. If your listeners want to email me, they can do so, and I can try to hook them up with people I know who might be in their states. One of the things I wish we had was a much more robust infrastructure to let people plug in. But that's something we need to think about how to do. It's as you're sort of in the midst of the fight, it's hard to think about your sort of long-term sustainability and planning. But that's sort of one of the deficits of our movement, that we sort of are so caught up in the present that we don't have time to plan and to think about the future.
Well, we should probably wrap up, but I want to just take a second as we're closing out, Greg. I mean, you're writing the column for The Nation. I see you in the media all the time. I'm not quite sure. Maybe you don't sleep, but how's the other work going? I mean, your opioid addiction work, HIV, AIDS work. Give us a little bit of a snapshot of that and what we can look for. I'm not going to say when the pandemic is over, but next phase of work for you coming out of this.
Well, one is I'm like running on lots of adrenaline, and it's unsustainable. Like I started Lipitor the other day. Like I'm not. Like the pandemic is not coming to me in the form of SARS-CoV-2, but it's coming to me in form of sort of like other health sort of issues. And so like one is like people should take care of each other and take care of themselves to get through this moment. I'm interested in the health of people who use drugs, and that means preventing overdose, reducing the transmission of HIV. And I continue to work on those issues with my research group and with my colleagues at Yale and across the country. The opioid epidemic exploded during the COVID pandemic, and nobody was paying very much attention. And so I'm trying to figure out a way to balance my life, both for my own health, but also because I think it's really, really important to start to think about the rest of sort of the world of health, that it's going to be there when we start to stop thinking about COVID and realize how worse everything has gotten in our absence as we've all sort of worked against this new pandemic.
Just a reminder, you've been listening to COVID Calls, and you can usually catch COVID Calls live at 6 p.m. Eastern Time. And I want to thank my guest, Greg GONSALVES, for your generosity of time today and talking about your background in research and activism and bringing us up to speed on what we can do now about this pandemic. Thanks, Greg, and take care of yourself, but also keep it up.
Thanks, Scott. Great to be here.
Stay healthy, everyone. We'll see you next time on COVID Calls.